Thank you for the opportunity to review concepts related to long-term follow-up care after childhood cancer. I'm Dr. Melissa Hudson, and I direct the Survivorship Division and After Completion of Therapy program at St. Jude Children's Research Hospital. The objectives of today's talk are for attendees to appreciate how childhood cancer treatment affects long-term health, to understand the spectrum and burden of late effects of childhood cancer, to understand the concepts of risk-based survivorship care, and to identify standards of survivorship care. Let's start with recognizing that survival rates for childhood cancer continue to rise, such that in the United States, more than 80% of children with cancer will achieve 5-year survival, as illustrated in this figure based on data from the National Cancer Institute's Surveillance Epidemiology and End Results program. Comparable survival rates are seen in high-income countries and increasing numbers of long-term survivors in low and middle-income countries. Contributors to this progress include participation in collaborative clinical trials, elucidation of cancer pathobiology that has been translated into novel therapeutics, advances in diagnostic imaging, radiation technology, and supportive care, and recognition of late effects. However, survival comes at a cost as children and adolescents treated for cancer are at increased risk for late effects that encompass a spectrum of physical and psychosocial morbidities as illustrated in the figure. These late effects may affect growth and development, organ function, prospects for future fertility and reproduction, risk for subsequent carcinogenesis, and many aspects of psychosocial functioning. Late effects are typically related to a specific cancer treatment modality, but may be related to the cancer experience and its subsequent impact on the survivor and family. Importantly, late effects of some type are reported by virtually all survivors. Overall, progress in therapy has changed the spectrum of late effects for childhood cancer survivors. Life-threatening toxicities are less commonly reported among children with biologically responsive cancers following increased understanding about therapy and dose relationships with specific late effects like cardiomyopathy, pulmonary fibrosis, or secondary AML. But curative cytotoxic therapies still leave many survivors with life-altering conditions such as cognitive deficits, infertilities, and conditions listed on the slide that may adversely affect their quality of life, or conditions affecting metabolic, immune, endocrine, or organ function that may worsen over time and become life-threatening. Despite gains achieved in childhood cancer, treatment-related multimorbidity contributes to a disparity in survival with increasing time from diagnosis compared to individuals without cancer, as noted in this childhood cancer survivor study analysis. One will note that cumulative mortality increases by 40 years to 23%. Health-related mortality, represented in the red line, is a major contributor to the increasing all-cause mortality, represented in black, with increasing time from cancer diagnosis. This is concurrent with a decline in mortality related to primary cancer recurrence or progression, and stable mortality related to external causes. Recognition of late effects and the associations between specific cancer treatments and late health conditions have been a key stimulus for change in cancer therapy. Early clinical observations associated radiation with musculoskeletal growth deficits, while later cardiac events and subsequent malignant neoplasms were observed and then systematically studied to confirm risk. These observations are instrumental in the development of frontline therapy that is risk stratified based on cancer biology and presentation in response to early therapy to reduce exposures to cytotoxic agents and modalities with the ultimate goal of limiting late toxicity without compromising cure rates. These data also informed risk-based health surveillance linking exposure with acute, persistent, or late effects that is performed during and after therapy. Thus, contemporary pediatric oncology care across the survivorship spectrum uses primordial and primary prevention measures starting at cancer diagnosis in a pediatric healthcare system, largely focused on delivery of risk-adapted therapy, considering cancer and patient-related factors. Effort shifts to secondary and tertiary intervention measures when long-term survival is achieved, such as health education, health screening and surveillance, and implementation of risk-reducing interventions. This should continue following the transition of care from a pediatric to an adult healthcare setting to optimize the survivor's health and quality of life outcomes. There are challenges with care transitions from a survivor and family perspective. Survivors and their families may be uninformed about the details of their cancer history. They have a strong bond with the treating clinicians and fear transition. Challenges from the oncology provider's perspectives include the fact that they want to see long-term survivors. They may not prepare the survivor or the primary care provider for a care transition. They may not be informed about survivorship issues, and they may not consistently address preventive care. Primary care providers also face challenges as they are typically unfamiliar with survivor health issues, as pediatric cancer subtypes are numerous and diverse, and treatments are also diverse and constantly evolving. They have limited incentive to develop expertise because pediatric cancers are relatively rare, and they may be uncomfortable caring for survivors, especially for those who are medically complex. Obstacles to transition of survivorship care from the cancer center to the community are particularly relevant to address as the frequency of late effects increases with increasing time from cancer diagnosis, concurrent with a decline in follow-up care at the cancer center, where presumably more providers will be familiar with recommended care. There are several standards used in the delivery of survivorship care, including clinical practice guidelines, survivorship care plans, and models of survivorship care. The goal of these standards aims to provide a survivor access to resources to address biomedical, functional, and psychosocial sequelae. The development of clinical practice guidelines for pediatric cancer survivors has been challenged by several factors, including the fact that it is a relatively small population, as pediatric cancers represent less than 1% of all cancer diagnoses. Pediatric cancers are clinically heterogeneous and represent many histologic subtypes. Their treatments are diverse and evolving over these past 5 to 6 decades. Survivors have unique vulnerabilities related to age and developmental status, and there is a delayed onset of many cancer and treatment-related toxicities, often years after cancer and during adulthood. Consequently, pediatric guideline development has used a hybrid approach linking evidence from the medical literature about outcomes to specific therapeutic exposures, allowing for the identification of high-risk categories for screening. Typically, because evidence about the impact of a screening intervention is often lacking, such as a mortality benefit, screening recommendations are often based on clinical experience, matching the magnitude of risk with the intensity of screening. This hybrid approach is highly featured in survivorship guidelines developed by pediatric cooperative groups and institutions. An international collaboration was established in 2010 to harmonize surveillance recommendations for more highly prevalent late effects developed by individual groups. This effort aims to optimize the use of expertise across many disciplines to harmonize national guidelines, reduce duplication of effort by many groups, establish standards of survivorship care, improve the quality of survivorship, identify a research agenda, and enhance research opportunities. The International Guideline Harmonization Group has been successful in harmonizing numerous surveillance recommendations, as noted on this slide, with several more harmonization efforts in progress. Importantly, breast cancer surveillance recommendations have been updated as new information emerged from the literature, and an update of cardiomyopathy surveillance recommendations is nearing finalization. There are several approaches that have been used for guideline development. In pediatrics, exposure-based is commonly used with screening and counseling based on specific chemotherapeutic agents, radiation doses and volumes, and surgical procedures. An alternative approach used by some is a disease-based guideline that focuses on modalities and health concerns related to a specific malignancies. This is a compelling approach as information about treatment exposures may not be available for a given survivor, but this strategy would have to consider how treatment protocols have changed over time and may vary based on an individual survivor's cancer stage, biology, and early response to therapy. Organ system-based and symptom-based guidelines are useful but may not address the diversity of late effects experienced by pediatric cancer survivors. The development of a survivorship care plan is another standard for survivorship care. The contents of the survivorship care plans vary widely, however, many include diagnostic information about the cancer, cumulative treatment exposures, clinical events and their status, transfusion history, family history, cancer-related health risk, health behaviors modifying risk, and risk-based screening recommendations. On the right, you can see a template of a simple survivorship care plan that includes a number of treatment-related milestone and surveillance guideline recommendations tailored to the risks unique to the individual survivor. Oncology providers should be mindful of the action required to implement a care plan, whether the information is summarized on a printed or online document or in some other format. The care plan is a process, not a piece of paper, and calls for the oncology team to consider specific cancer history and treatment, to specify a primary cancer surveillance plan, to outline cancer and cancer treatment-related health risks, to detail subsequent cancer and late effect screening, to address lifestyle impact on cancer-related health risks, to include screening for and management of comorbid conditions, to optimally coordinate the care, define roles of involved providers, and to assist the survivor in identifying resources to address medical and psychosocial needs. Survivorship care planning should also consider the model of care available in the community, as follow-up care in the cancer center declines over time and survivors may not have access geographically or financially to a specialized long-term follow-up program. Long-term follow-up care after completion of therapy varies regionally and by national health systems and resources. Some survivors will have access to special long-term follow-up clinics or to an oncology clinician to share care coordination with primary and subspecialty care providers in the community, but generally this is a very small proportion. Most long-term survivors will age out of pediatric cancer programs and receive care by community health care providers who are unfamiliar with late effects and the special health needs of childhood cancer survivors. Because of this, survivorship care remains an important focus of study, especially care of aging adults treated for cancer during childhood. Our deficits in preparing survivors for transition of care were highlighted during the SARS-CoV-2 pandemic. Many long-term follow-up programs suspended or restricted care. Long-term survivors who were solely dependent on care from the oncology team scrambled to find local services. Efforts were renewed to enhance communication with and promote early transition to local healthcare providers. Our experiences have shown us that risk stratification of survivorship care, initially implemented to limit contact during the pandemic, will likely continue post-pandemic. Risk-stratified survivorship care was first proposed by oncology clinicians in the United Kingdom and featured different levels of care based on the type and stage of cancer and intensity of therapy. Post or telephone follow-up every 1 to 2 years was proposed for level 1 survivors treated with surgery alone or low-risk chemotherapy. Nurse or primary care follow-up every 1 to 2 years was proposed for level 2 survivors treated with chemotherapy and low-dose cranial radiation. An annual follow-up in a medically supervised late effects clinic was recommended for survivors treated with more intensive chemotherapy and radiation therapy. While potentially feasible in a country with a national health insurance system, care stratification limited to cancer and treatment factors fails to address barriers to care, especially psychosocial and health system barriers that may exist in countries without universal health care access. Risk stratification of survivorship care that addresses psychosocial factors influencing access to care remain an emerging area of survivorship research. Extensive research has described a variety of patient, provider, cancer-related, and healthcare system factors associated with risk of late morbidity and mortality experienced by survivors that are mediated through access to survivorship care. This knowledge has been used to guide therapy changes as well as inform survivorship care, clinical education programs, and healthcare policy to improve outcomes for children with cancer. Patient factors that pose barriers to survivorship care include cognitive and developmental status that affect understanding of health risks, health knowledge and health risk perceptions and self-efficacy to engage in survivorship care, and insurance and resources to access care. Barriers to survivorship care may exist at the provider level, as a provider's ability to facilitate or advocate for care and resources is related to his or her survivorship education and training, survivorship experience, practice style, perceptions regarding preventive care, access to survivorship resources, and knowledge and access to an individual survivor's health history. Finally, healthcare system factors can have substantial impact on a survivor's access to care and community resources, as well as communication and networking among providers. Consideration here include financing and payment policies within healthcare systems, the organization and affiliation of providers, data systems and information sharing, for example, through a common electronic medical record, models of survivorship care, insurance coverage and benefits supporting survivorship care, especially preventive and psychosocial services, community resources, and survivorship advocacy activity. These data underscore the importance of anticipating risks associated with the cancer experience that may make a survivor more vulnerable to adverse outcomes. High-quality survivorship care is risk-based in that care considers factors noted on this slide which influence the risk of late effects, as well as factors that affect a survivor's ability to access that care. Most often, these focus on the survivor and provider, but can be facilitated or challenged by the healthcare system. With the establishment of follow-up programs, it is important to assure that trainees and medical staff involved in survivorship care attain specific competencies. These include recognizing that childhood, adolescent, and young adult cancer survivors are a growing population with substantial premature mortality, chronic morbidities, and risk of subsequent neoplasms. They should be familiar with long-term surveillance guidelines based on exposures. They should be able to provide childhood, adolescent, and young adult cancer survivors with appropriate risk-based care, and recognize that requests for use of and discussion of cancer survivorship care plans with survivors can facilitate delivery of evidence-based or best practice follow-up care. Evaluation of follow-up programs have largely focused on measurement of patient-reported outcomes, symptoms and health status, survivor knowledge, screening and surveillance performance, and wellness and health promotion activities. It will be important to extend these measures to address other salient survivorship issues, such as program structure and cost, survival and quality adjusted life years, functional status, inclusion of supportive services addressing psychosocial, nutritional, rehabilitation needs, as well as fertility preservation and advancement of health equity. In summary, I hope that you appreciate through this presentation that childhood cancer survivors are at increased risk for chronic health conditions that can affect the quality and duration of survival. Cancer treatments have been modified over time to reduce treatment-related exposures that increase risk for adverse health outcomes. Risk-based survivorship care that incorporates routine health care, personalized surveillance and screening, and management and prevention of late effects is recommended for all survivors. Follow-up care for survivors should aim to anticipate health risk and facilitate survivor access to surveillance and resources. Thank you for your attention. I look forward to learning more about your experience in developing and implementing follow-up care in your centers.